Today's my presentation is oncologic and the long-term outcomes of the laparoscopic and open extended cholecystectomy for gallbladder cancer. As we know that gallbladder cancer is the most common malignancy of the biliary tract, and most present late because of the non-specific symptoms, and they will present at the locally advanced disease when the cure may not be possible. And this is an aggressive tumor, so most of these patients present late at and locally advanced stage. Also, there's some patient present with the jaundice also. Also, the role of neoadjuvant therapies is coming up, but as such, there is no solid evidence of the role of neoadjuvant chemotherapy or chemoradiotherapy in gallbladder cancer. So the most effective therapy remains the surgical resection, and especially the extended or both the terminologies, either extended or radical, they are used in literature. That is extended cholecystectomy, that is en bloc resection of the gallbladder cancer liver bed, and that is either wedge resection or the segment 4B5 resection, and the hilar lymphadenectomy including the retropancreatic lymph nodes. And as we know, the open radical cholecystectomy has already been established as the gold standard for the gallbladder cancer. This is the Japanese registry data present long back, published long back in 2009, and it was total data of the almost 5,584 patients, and in that gallbladder cancer were more than 2,000 patients. And with open radical surgery, the good reasonable survival was achieved in the stage 1 87% and stage 2 68%. Also in locally advanced disease, also the reasonable survival was achieved. This was a recent publication from the Tata Memorial Hospital, and they have come up with the concept of multimodality treatment. This was results of the more than 500 patients, with 400 patients were confirmed histopathology of gallbladder cancer, and out of that 80 patients were disseminated disease, and the remaining patients underwent open radical resection with perioperative chemotherapy or chemoradiotherapy. And in that study, almost more than 100 patients, they received pre-op chemotherapy, and 200 patients received adjuvant therapy in the form of chemotherapy or chemoradiotherapy. And with this multimodality treatment, they have achieved the reasonably good disease-free survival of 34 months, even in the locally advanced disease. And in their group, the percentage of the locally advanced disease was around 40%. So now already the role of staging laparoscopy has been established in gallbladder cancer, and this was the landmark publication from the GB Pant Hospital in 2013. And they especially assessed the role of staging laparoscopy in gallbladder cancer. This was data of more than 400 patients. And in the yield of staging laparoscopy to find the detectable lesions, that is peritoneal deposits and the surface liver metastasis, was around approximately 23%. The yield was higher in the locally advanced disease as compared to the early disease. That was 25% versus 10%. And also, because of this staging laparoscopy, they were able to avoid the unnecessary laparotomy almost in 56% of the patients with locally advanced disease, and almost 1/3 of the patients with early stage disease. They also proposed that the use of additional laparoscopy port in the incision site of the definitive surgery to assess the hidden deposits, especially in the undersurface of the liver, in omentum and in infracholine compartment, to increase the accuracy of the staging laparoscopy to 100%. But there was a debatable issue that the role of laparoscopic approach for the radical cholecystectomy, because of the issues associated with the laparoscopic approach. The main is the technical expertise, especially you require highly experienced surgeons for the liver resection and to do lymph node clearance in the HDL, especially around the hepatic artery and the retropancreatic area. And there is a steep learning curve because of this required technical expertise, and some series have reported the conversion rate up to 30%. Also, you require the need of advanced instruments like laparoscopic CUSA and harmonic for the liver resection. And also the main important issue is that there is a doubt regarding the oncological safety of the laparoscopic approach because of the scarcity of the data around the laparoscopic approach. There was a new wave of laparoscopic surgery in the gallbladder cancer based on the more upcoming experiences in the role of laparoscopic radical surgery established in the gastric cancer and the colorectal cancer. This was the first landmark publication by the Professor Han and Professor Young from the Bundang Hospital, Korea. Initially, they did the 36 cases with suspected GBC, and it was a highly selected group of patients. and they did a laparoscopic approach in 30 patients. In that they used the combined modality, that is CT, endoscopic ultrasonography and laparoscopic ultrasound to assess the liver infiltration in this group of patients, and they almost predict the negative predictive value of almost 100%. And they did a Foson section analysis. In that 18 patients were found to be gallbladder cancer, and they did additional laparoscopic lymphadenectomy, and in that they removed the gallbladder with a small wedge of the liver. The total lymph node dissected were almost 4 to 21 with median of 8. And this followed this patient. It was intention to treat analysis. The median follow-up was 27 months, and they reported no evidence of any tumor recurrence or port site recurrence. Subsequently, the few authors from India also started the laparoscopic approach for radical cholecystectomy. This was the first publication from the GB Pant Hospital in 2015. And it was also a retrospective analysis of the patients which underwent a laparoscopic radical cholecystectomy from June 2011 to October 2013. The inclusion criteria were the primary GBC with or without or limited liver infiltration on the preoperative CT abdomen. They also included the IGBC patients with stage 1B and up to stage 3, that is with the muscular involvement and up to the limited liver infiltration. Total 24 patients underwent laparoscopic approach, and 46 they compared the results with the open radical cholecystectomy patients of 46. And the extent of liver resection was the segment 4B and 5 in all the laparoscopic group. The lymph node yield was comparable in both the groups, that is the laparoscopic group and the open group. Also, the stage of the disease was comparable, though slightly early stage disease was more in the laparoscopic group. The R0 resection was 100%, and there was a median follow-up of 18 months. It was a short follow-up, and only one patient developed in the open group epigastric port site deposit, and none of the patients in the laparoscopic group developed any port site recurrence. Subsequently, the publication started coming on the long-term outcomes, and this was a 10-year prospective cohort study from the same group, that is Professor Han from the Bundang Hospital, Korea. This was a retrospective analysis of the GBC patients from May 2004 to April 2014. And this was also the highly selected group of patients with the use of combined CT, endoscopic ultrasonography, and laparoscopic ultrasonography. They especially considered the patient with early stage gallbladder cancer, mainly T1 and T2, with no liver invasion. The extended cholecystectomy performed in 32 patients and the simple cholecystectomy in 13 patients. The R0 resection was 100%, and the lymph node yield was 7, that is equivalent to the open group. And the T-stage distribution was the T1, T2 patients were respectively 18 and 25, and the 5 patients were lymph node positive. The median follow-up was 60 months, and the 5-year disease-specific survival they reported 94.2%. The 4 patients developed the recurrence. There was no port site recurrence, and it was only the distant metastasis. They also analyzed the survival the stage-wise, and in the stage 1, T1 patients had a 5-year survival of almost 100%, with the 90.2% survival in the T2 group of patients. Subsequently, the Palani Value group from the GEM Hospital from India, they published the long-term outcomes of the laparoscopic radical cholecystectomy in gallbladder cancer. This was also the small group of patients, and they analyzed the data from 2008 to 2013. They performed the laparoscopic radical cholecystectomy in 14 patients with early disease, and also the extent of liver resection was the segment 4B and 5. And total they have found the 12 patients had adenocarcinoma in final histopathology. The median follow-up was 51, range from 14 to 70 months, and they reported the 5-year overall survival of 68.5%. Also, the T2 stage was 8, and T2 N1 was 3 patients. And there was one patient was T3, in that they did the CBD excision for the radical resection. This was one more publication from the, again, GB Pant Hospital, analyzing the long-term outcome. This was done by the Professor Nag. It analyzed the outcomes from the July 2011 to July 2018. They compared the 30 patients of the laparoscopic group with the 38 patients of the open group. And the incidence of incidental gallbladder cancer in the laparoscopic group and the open group was 11% and 6%, 11 and 6, that is 36.6% and 15.7% respectively. And the 7 patients were underwent conversion to open because of the technical difficulties, and it was intentional treat analysis, and it was finally considered analysis in the laparoscopic group only. They compared the both groups, laparoscopic group and the open group. The lymph node yield was comparable. Also, the negative margin, even including the liver margin, was comparable. The stage distribution was also the comparable. And they also assessed the recurrence after the median follow-up of around 34 months. The local recurrence, distant recurrence was also comparable. The 50% of the patients in both the groups, they received adjuvant treatment, that is gemcitabine based, and the RFS and overall survival was also comparable. And if you see the survival curves, the laparoscopic group had a slightly better survival as compared to the open group because presence of the slightly higher number of early stage disease and IGBC patients in the laparoscopic group, but it was not statistically significant, both overall survival and the recurrence-free survival. And the median follow-up was around 18 months, the range from 6 to 34 months, and the only few patients developed recurrence. That was in laparoscopic group, only one patient had a lymph node recurrence at 14 months, none of the patients developed port site recurrence, and in the open group, the 3 patients had a recurrence, that was nodal recurrence in the 2 and liver metastasis in the 1. This was next publication from the again Korea, the same group, that is Bundang Hospital, and they published their 13-year experience, especially in the T2 gallbladder cancer, the laparoscopic and open resection, and they analyzed the 54 patients in the laparoscopic group and 44 patients in the open group, and they reported the comparable disease-free survival in both the laparoscopy group and open surgery group. That is 5-year disease-free survival of 78% in the laparoscopy group and 62.4 in the open group.
Nilesh, you are showing so much.
And this was a consensus statement that was a meeting conducted at the Korea. There were all the surgeons from the India, Korea, Chile, and Japan, and it was concluded that the laparoscopic the role of laparoscopic surgeon in the radical cholecystectomy for gallbladder cancer is evolving, and in expert hands, the reasonable survival can be achieved, especially in the early gallbladder cancer. And this was recently published from the data from the West, and it was published from the National Cancer Database. It was a 7-year experience from the US, which has accredited the more than 1,500 centers, and the study was analyzed from the 2010 to 2016. There were 235 patients in the minimal invasive group and 445 patients in the open group. Almost 1/3 of the patients underwent conversion to open. The R0 resection, lymph node yield, the tumor grade, and the stage distribution was comparable. And they also concluded with the laparoscopic approach, the overall survival is comparable between the stage 1, stage 2, and stage 3 patients. They also did analyze the factors predicting the overall survival, and the type of the surgical approach was no impact on the overall survival. And importantly, the stage of the disease, the lymph node positivity, and the blood loss more than 500 ml, and the residual disease at the GB bed had the most factors predicting the survival. This was the initial table showing initial studies of the laparoscopic approach from 2010 to 2016. The numbers were very small, almost less than 25, and most of the patients, almost 3 studies, they analyzed the primary GBC patients. T3 patients, that is involving liver and adjacent single organ, were small numbers, that is less than 10. Conversion to open was in one patient and 10 patients in one study. The lymph node yield was almost comparable to the open approach. All the majority of studies, they did the aortic level sampling. The oncological outcome, the stage of the disease was comparable in all the groups. The margin positivity, the assessed in 3 studies, and it was comparable. Follow-up months was 27 months. These are all the short follow-ups in all the studies. And the recurrence was happened in very few, and none of the patients, they developed port site recurrence. These are the important studies which have analyzed the laparoscopic versus open group, comparing the long-term and oncologic outcomes. There was one study, 2 studies were from the India, that is the Professor Nag and Polanevelu, and all the groups were small. The laparoscopic group varied from the 6 to 32 patients, and also they included the small group of patients with the T3 stage of the disease. The lymph node yield was comparable. Aortic sampling was performed in the 2 studies, and the stage of the disease was comparable. The surgical margin, that is R0 resection, was comparable in all the studies. The median follow-up was varied from the 24 months to the 64 months, and they reported 5-year survival of almost 68 to 94%. The most important issue to be addressed in the laparoscopic approach is the port site recurrence and the impact of the port site excision on the outcomes. This was the first study to report the incidence of port site recurrence following the laparoscopic gallbladder resection for the IGBC. This was experience from the multi-center experience from France. And they performed 148 patients underwent curative resection for IGBC, 54 underwent port site excision, and 94 patients there was no port site excision was performed. The T and N stage was comparable in both the groups, and only one patient had a T3 had a port site metastasis. So they compared both the patients for survival analysis, and in the overall survival and the recurrence-free survival was comparable in both the groups, that is port site excision and the non-port site excision. This was one more experience from the Memorial Sloan Kettering, that is USA experience. And they analyzed the data of 113 IGBC patients. In that, 69 patients underwent port-site excision, 44 don't, and 13 had almost 19% patient had a port-site metastasis in the group of patients who underwent port-site excision, and all these patients has a locally advanced disease that was T3 to T2, T3, and the lymph node positive disease. And they concluded they analyzed the patients who underwent R0 resection between the patient who had a positive port site metastasis versus negative port site metastasis. It was only 6 patients, and they reported that it was they have very poor survival, and they concluded that the port site metastasis basically denotes the carcinomatosis. And in this group of patients, almost 77% patients in the 13 patients and the 30 versus 34 patients. It was statistically significant. But important to note that both of the studies, the port site metastasis is not the poor prognostic factor. The poor prognosis is because of advanced stage of the disease. All these patients had a T3 disease, lymph node positive disease, and both the studies, then they have not reported the data on the whether there was a bile spillage was happened in the index surgery, the integrity of the specimen, and also the this, after that, they compared the data of the patients with port resected versus non-resected. Again, it was comparable. Both the studies are from the US and France, and most of the centers in the US, France, they use the plastic bag for retrieval of the specimen. In Indian scenario, this is a different. Most of the hospitals in the periphery, they don't use specimen bag. So it was basically the mechanical factor which plays in the role for the seeding of the cancerous cell, that is improper the manipulation of the tumor and the bile spillage, which play important role in the port site metastasis. This was again this was data from the MD Anderson Center and Chile. They have analyzed the recurrence pattern following the laparoscopic resection and the open resection, that is the radical cholecystectomy for the IGBC. And both the groups, the pattern of the recurrence was comparable, except in open group, they reported the higher carcinomatosis as compared to the laparoscopic group. But if you see the carefully, the open group had a more locally advanced disease. They were lymph node positive disease. And again, they also reported they did multivariate analysis, the factors impacting on the survival. The type of the surgery didn't have an impact on the overall survival. This was a recent review published on the port site metastasis incidence in the gallbladder cancer. The data was extracted from 27 studies, and they analyzed the trend in the port site metastasis, the historic era, that is published before the 2000 versus the modern era. The incidence has dramatically reduced from 18.6% to the 10%. The main reason was there because of the better preoperative prediction of the gallbladder cancer, because of the availability of the advanced imaging. Next, the proper manipulation of the tumor-bearing organ and avoidance of the bile spillage during the surgery, and also the improvement in the technical expertise. And they found that the extraction port site is especially important in the Indian scenario. They are most of the higher risk, and 63% of the patients, they have found the isolated extraction site recurrence. And as compared to the MS cases, they reported the port site metastasis is the poor prognostic factor. But if you see carefully, these few patients with isolated port site metastasis, which has the good disease-free interval from the index surgery, and they have no any evidence outside the abdomen, they can undergo surgical resection, including especially in the epigastric port or the right hypochondrial port. You have to do sometimes axillary clearance of the lymph node dissection. They can reasonably good survival can be achieved in this group of patients. And the same thing was reported out of the 16 patients were alive at 2 years following the surgical resection, and they had no recurrence in the 14 patients. And also in 2 of these patients, one patient had a lymph node disease and one patient had the residual disease at the liver at the time of the surgery. This was the systemic review meta-analysis published in 2021, and this included those 2 studies from the India, and other studies were from the China and Korea. They included the studies till 2019. The total were 64 patients, 654 patients. They analyzed 287 in the laparoscopy group and 367 in the open group. And they reported the oncological outcomes, the lymph node yield, the R0 resection rate, and the scar recurrence was comparable. This was one more meta-analysis recently published in Ages in 2022, and they analyzed 14 studies till April 2021. Total more than 1,000 patients were analyzed. In that, 1,052 patients were laparoscopy group and 740 patients in the open group. And the tumor stage was the most of the patients in the laparoscopy group were early stage. The T3 disease were few numbers. Most of the studies reported the less than 10 numbers in the laparoscopy group. And they reported the laparoscopic approach, they increased the survival in the T2 and both the T3 patients, almost early survival, especially 1 year, 2 year, and 3 year. Also in the T3 group of patients, they increased the laparoscopic survival. They found the higher survival, 25%, 18%, and 13% in 1 year, 2 year, and 3 year. But one should carefully analyze, see this data, because T3 group of patients was very small. Most of the studies that reported the number was less than 10. These all are the retrospective studies with the small sample size. There are lots of heterogeneity in the data, especially the selection of the patient for the treatment modalities. And they also analyzed the recurrence rate versus laparoscopic open. It was a comparable, and during this, the port site metastasis was happened only in 4.5% in the laparoscopic group. This also suggests that port site metastasis is no more obstacle for the laparoscopic approach in the gallbladder cancer. It happens similarly, that happens as wound seeding happens in the open surgery. Also, it happens in the laparoscopic radical surgeries for the gastric cancer and the colorectal cancer. So I propose the algorithm, what you are the based on the evidence in the literature. If there is a suspected GBC based on the clinical or radiological suspect, you should do basic investigation, that is LFT, tumor markers, NCCT chest with CACT abdomen, triple phase including pelvis. The role of MRCP is optional because newer CT you can assess the level of block as equivalent to the as MR. Also, the role of PET-CT is also optional in the gallbladder cancer, especially it is don't even require a multi-organ resection, or the patient is borderline. You want to rule out some the nodules which are non-characterizing in the CT. If in this on the staging, if you find any lymph nodal disease, especially in intra-aortic or para-aortic area, that is N2 group of disease, which is to the left of the celiac axis, SMA group, you should sample this lymph nodes by the US and do FNAC. Also, the US will help the accurate staging. If you are planning for laparoscopic radical cholecystectomy, it will help in accurate staging of the gallbladder cancer, including the liver invasion. Subsequently, you do the staging laparoscopy. You assess the extent of the disease by putting additional port. You also detect the additional hidden deposits under surface of the liver in the omentum, infracolic compartment, and you do intravertebral sampling laparoscopically, and you send for frozen section. The role of frozen section is also there, especially you are doing you are suspecting GBC based on the which is a thick wall GB, and the ultrasound and CT findings suggest that there is a high risk chance of malignancy. You do remove the gallbladder along with the wedge of the liver, and you send for the frozen section. Based on all these modalities, you assess the extent of the tumor. If it is a early GBC and there's a limited liver infiltration and recent adjacent single organ involvement, especially duodenum, colon, and CBD, you can these patients you can go ahead with the laparoscopic radical cholecystectomy. As such, the data in the locally advanced stage, that's T3 and T4, is very scarce. So patients with multivisceral involvement, extensive liver involvement, combined duodenal-pancreatic infiltration with biliary vascular involvement requiring major hepatectomy, and if there are the bulky lymph nodes in the hepatic artery and retropancreatic area, this patient should be considered for the open radical cholecystectomy. This is IL-based experience of gallbladder cancer from 2010 to July 2022. Before presenting this data, I want specially thanks to my senior residents and Dr. Guresh, who helped me analyzing this data. This was the total 150 patients gallbladder cancer underwent surgical exploration. In that, 132 were primary GBC and 26 were incidental or missed. In primary GBC, on staging laparoscopy on intravertebral sampling, 60 were found to be metastatic. In that extended cholecystectomy, that was either wedge liver resection or the segment 4B5 was performed in 49 patients. The major hepatectomy was performed in 18 patients and HPD in 5 patients. And this HPD included all our major hepatectomy, that is modified extended right hepatectomy, that is segment 4A preserving in 3 patients, and extended right hepatectomy in 2 patients. In IGBC, 6 found to be M1 disease on staging laparoscopy or intravertebral sampling. 1 patient underwent HPD, and 19 patients underwent completion extended cholecystectomy. In that, out of 19, only the port site excision was performed in 5 patients, and only 1 patient we detected the port site deposits. And also in HPD, the hepatectomy performed was the extended right hepatectomy. This was a demographic profile, and the median age was 52.5 years. Almost 40% of the patients were performed more than 60 years of age. There was a female predominance for the gallbladder cancer. This was the presentation of the patients. Almost 30.34% of the patients presented with jaundice. The most common presentation was the pain abdomen, and next is followed by the weight loss and anorexia. These are the median tumor marker level. The CA19 was 82 and the CA was 2.42. The few patients require preoperative optimization. We used the 22 patients received the neoadjuvant chemotherapy, that was gemcitabine and cisplatin. And out of this 22, only 10 patients we subsequently found to be the metastatic, either on staging laparoscopy or intravertebral sampling. The preoperative biliary drainage was performed in 52 patients out of 56 patients, jaundice patients. And of that, the definitive resection was performed in only 40% of the patients. We use pre-op potlone embolization, especially for the augmentation of the feature liver remnant in 12 patients. This was the type of liver is a major hepatectomy performed in gallbladder cancer. There is 12 patients underwent modified extended right hepatectomy, 3 patients underwent extended right hepatectomy. We performed the extended left hepatectomy in 3 patients because it was a left-sided gallbladder in these 3 patients. That is, the gallbladder was to the left side of the MHV, and 6 patients underwent major hepatectomy along with pancreaticoduodenectomy. This was the potlone embolization in extended right. All 3 patients underwent potlone embolization before surgery. In modified extended group, the 5 out of 12 patients required potlone embolization. None of the patients required, that is, none of the patients of extended left hepatectomy required potlone embolization. And 4 out of 6 patients of HPD we did potlone embolization prior to the surgery. This was number of other organ resected. Almost 1/3 of the patients require adjacent organ resection. In that, adjacent organ resected were duodenum, colon, CBD. We performed potlone resection in 3 patients. In that, 2 were segmental resection, 1 was sleeve. And we also performed the arterial resection, that was common hepatic arterial resection, in 1 patient. And the mean duration of surgery was 215 minutes, and the mean blood loss was 280 ml. This is the post-operative complications. We require 2 patients required re-exploration for the bleeding. 19 patients developed post-op sepsis. 5 patients had a post-hepatic liver failure. Importantly, all these 5 patients they developed post-hepatic liver failure following the episode of sepsis. And all these patients were preoperatively underwent biliary drainage by either ERCP or PTBD. 13 patients developed bile leak, and most were managed conservatively. 4 patients had an enteric leak. 1 patient of HPD developed PJ leak, and 7 patients underwent PCD for intra-abdominal collection. The major morbidity, that was Clevin-Dindo, assessed by the Clevin-Dindo, more than 3 was almost 24%. During the study period, total 5 patients had a in-hospital mortality. The first, all were locally advanced disease. The patient 1 underwent.
Summarize now.
Yeah.
Summarize.
The 2 out of 6 patients of HPD also had a mortality. This was the stage distribution of our patients. Majority were locally advanced. Almost 60% of the patients were lymph node positive, and were good number of patients with T3, T2 and T3 were performed. Almost more than 60% of the patient had a LVI, 57% patient had the PNI, and 43% received the adjuvant therapy in the form of gemcitabine plus cisplatin. This was the survival analysis was performed stage-wise. The stage 1 patients had a very good survival. Stage 2 had a 5-year survival of 72%. None of the patients of stage 3 and stage 4 they survived at 5 years. This was T stage by distribution of the overall survival. The T1, T2 had very good survival. The T2, the 5-year survival of T2 in 66 patients, because almost 10 patients had a lymph node positive disease. The overall survival was bad in patients with T3 and T4. And this was a lymph node wise patients with lymph node positive disease had a poor survival with 5-year survival of only 15.3%. This was a disease-free survival analyzed by the stage-wise, and the stage 1 had a 5-year disease-free survival was 77.9%, stage 2 had 26.9%. We had a slightly lower disease-free survival as compared to the published studies in the literature because of the presence of locally advanced disease, and almost 60% of the patients had LVI, PNI and lymph node positivity, and only 40% received the adjuvant chemotherapy. This was the recurrence-free survival by end stage, and patients with lymph node positive disease has very bad recurrence-free survival at 5 years. I mean, none of the patients survived at 5 years. Okay, thank you.